I'm going to present some of our findings on the impact of housing quality and characteristics among falls among all the people living in the community. So this is, as Steve said, this is a part of ESHCRU, and Jose Luis Fernandez, who is in the call, was also part of the research team. And these are the usual acknowledgement. One is for the funder, NIHR, and also the data, ELSA, that we use for this analysis. Just to give a bit of a background, so probably you already know, but in England, 1/3 of those aged 65 or older and half of those aged 80 or more experience at least one fall annually. So falls are a big issue among older people. Falls often result in fractures, lacerations, and also other injuries, and they can also have an important long-term negative impact on independence and well-being of older people. And as a result, of course, falls increase demand for both health and care services and their associated cost. So the main motivation for this research was the evidence gap. So there has been a focus on trying to identify which are the individual risk factors associated with falls. So among them, age, gender, frailty status. Going to minimize this, sorry, so you can see, and also health. And so they have been in the development of some e-tools calculator, where basically using mostly clinical data from GPs, it's possible to estimate the risk of a person to have a fall. And for those that have been at risk of having a fall, they have been given or tested different interventions and programs, for example, providing with vitamin D supplements, making modifications to their home, widening their doorways or installing ramps, etc. Also the use of technologies, for example, alarms when somebody feels dizzy, also exercise programs to increase the muscle strength, and also multifactorial interventions where basically an occupational therapist go to the home of older people and identify different hazards that can be associated or increasing the risk of having a fall. But the problem is that while it has been some exploration on housing conditions and housing problems, this has been a bit more neglected. So in fact, in 2018, there was a review published by Public Health England, where 26 studies, cost-effective intervention evaluations, were scrutinized, and many of them were not about housing. The majority was not about housing, and only 4 of them involved home assessment and modification, but there was no evidence on impact of housing quality on falls. In addition to that, the cost of falls and health and care in older adults hasn't been estimated for England. It was estimated for Scotland more than 10 years ago, but there was no an estimation for England. So basically, housing has been neglected, and that's why we thought that there may be an evidence gap there, because fixing housing is an avoidable cause, and therefore we could work on that. So there were 3 main research questions. The first one was, what is the impact of housing problem on falls and control for other risk factors? And here we deal with the issue between causality and association, and the idea was to really identify those housing conditions that were causing an increase on risk on falls among older people. The second research question was, what is the impact of housing-related falls on care patterns and associated costs? And here we look at health and care costs. And in care costs, we focus on formal care. So because of data limitations, we couldn't include informal care. And research question 3 was, what are the effects of home adaptations on health and care costs? And the data we used was from ELSA, so we used waves 1 to 10, everything what was available. That covered a period of time of 20 years, from 2002 to 2023. We include only people aged 65 or older, and we found that around 30% of the older population in our sample have had a fall, and that is consistent with previous statistics that I showed you at the beginning of the presentation. In terms of the housing problems that we explore, was having dam problems, general decay of the house, lack of space, plumbing issues, electrical issues, whether the accommodation was too cold, too dark, or noisy. And we found descriptively that around 20% of people in our sample had a housing problem, but those with a fall, there were a bigger proportion. 29% of them had a housing problem. And again, this is very descriptive. It's not controlling for other factors. And also you can see in the graph how when you have more housing problems, also the prevalence of falls increases. Here we are not controlling for the privation level, for example, that could have an effect on having bad housing conditions, but also on having an increased risk of fault. Yeah, so in terms of research question 1, which was to identify which factors were increasing the risk of having a fall, we found 2 main factors. The first one was having an electrical or plumbing issues, which sounds like 2 factors in fact, but they are together in ourselves, so we cannot separate them. And this factor really statistically significantly increase the risk of having a fall. And that makes sense because if there are electrical issues, they will be exposed or loose wires. That's a tripping hazard, could make people to fall. If there are plumbing issues, there could be slippery floors because of leakage. Could be the water damage the tiles and it create floor irregularities, and that may cause a fall. So it does make sense that this factor appear as relevant. The second factor was lack of space, and here is probably related with clutter, which is a tripping hazard, but also with obstructing exit and people making awkward movements and losing balance. I have to say that these 2 factors were always there, so it doesn't matter what methodology we use, what specification of the model we use, they will always consistently appear in our model as relevant when looking at the risk of having a fall. In these models, we also control for individual characteristics such as age, gender, marital status, education, care needs. We included activity of daily living and instrumental activity of daily living. Also, poor health, whether the person had long-term illness and disability, and also, and quite importantly, whether the person has had a previous fall. And we also tested different housing conditions. We also tested condensation, whether accommodation is too dark, the total number of housing conditions. And as I said, these 2 factors, they always appear as the most important when exploring an increase of risk of having a fall. In terms of tenure, we tested in and out of the model because obviously having been an owner occupied, for example, could help you to fix your home or could give you more kind of ownership in terms of being able to adapt your home if there are any problems. So we tested in and out. But in ELSA, there was also another question about falls, and that included a more serious fall that was identified by having a fall with healthcare use. The previous question I showed you was only having a fall. And here we again identified 2 main factors. The fact that there are 2 is coincidental. We didn't impose that. The first factor is the same, having an electrical and plumbing issues. And again, it could make sense for the same reasons I mentioned before. But there was a new factor that is associated to increasing the risk of having a fall with healthcare use, which wasn't identified before, and it was the accommodation being too dark. And again, this can make sense because it could be due to poor visibility of obstacles, and it's a tripping hazard. Difficulties navigating stairs, we could make the fall much more serious if somebody fall down the stairs. And also it could create visual confusion due to shadows. And as in the previous model, we also control for several individual characteristics. and also we tested for other housing conditions. So in research question 2, we look at which are the service used, the pathways, and also the associated cost. And here we develop a decision tree model. And for those that they don't know what it is, it's basically a visual representation of different pathways that people follow. So it is a tree in the sense that each branch represents a mutually exclusive decision or event and indicate what will happen next. And by following each of the branches, we can compare different options and the chances of happening and their possible outcome. And we use a time frame of 1 year for this analysis. In terms of the parameters and assumptions we use for to populate this tree, we use data and analysis from ELSA at the beginning of the tree, and then because the sample size become very small, we heavily rely on previous evidence. So on other studies that study falls. This is the decision tree model that we develop. You can see all the false pathways, and as I said, they only include formal care. And we started from the beginning, only including people, all the people that live in poor housing conditions. Some of them may experience a new fall. Some of them may not experience a fall, but they may have had a fall before. And some of them may have not fallen in the past or in the current period of time. For those that experience a new fall, some of them will call the ambulance, some of them will attend the GP practice, some of them will call 111, and basically some of them will not call anyone. Those that call the ambulance, some of them may attend A&E, some of them may not. Those that attend A&E, they can they may have had a hip fracture, another type of fracture, or they may have a laceration without fracture. Those that attend the GP practices, they could have been referred to a full clinic or a specialist, and sometimes they are not referred to anyone. So we created this different pathway. I think in total there are 12 different pathways or groups, and then we look at whether which is the likelihood that they use care services for each pathway. And we look at home care and residential and nursing care in the short term and also in the long term. And we estimated the cost, as I said, for 1 year. We estimated that the cost of living in poor housing conditions, the cost of falls for those living in poor housing conditions is 540 million. Healthcare, formal care was 991 million, which is around 65% of the total. And the total was, of course, 1.5 billion pounds. In terms of per person that fall and live in poor housing conditions was around 1,273 pound per person. I need to mention that this estimation represents the additional cost of falls that we can attribute to living in poor housing. It's not for everyone, and it's not for every type of falls. It's for those that were caused by bad housing. So when we look at research question 3, which are what are the effects of home adaptations on health and care cost, we estimated that they were reduced, healthcare was reduced by 25% when home adaptations were in place. The cost of care was reduced by 22%, and the total care cost was reduced by 23%. In terms of the limitation of this study, so first, ELSA, falls are self-reported, and I have problem with the stigma, with memory, because ELSA is asked, the questionnaire is every 2 years, so people may not remember. So issues with memory and also self-worth. People sometimes don't report that they have fall because they think people will see them as vulnerable. So maybe a problem of underreporting. Then the second limitation is that the decision tree model is a simplification of actual pathways, and we know that, and also that we rely on previous evidence. In terms of mental health services, this was a comment from people with lived experience. They told us that the fear of falling was quite important, but we didn't consider mental health services because of anxiety or frustration, that people couldn't move as they were moving before the fall. And that is also a limitation due to data constraints. Also, the total effect is likely to extend beyond 1 year, so we cap it at 1 year, but it may be longer. And so, for example, we didn't include readmissions, hospital readmissions, because of the fall. And the last one is that we assume that the consequence of fall do not vary depending on whether they relate to poor housing, and that can also underestimate costs. This is basically that we assume, because we really rely on the literature, that a fall in the middle of your living room with a perfect floor will have the same consequences that for people that live in poor housing conditions, where the fall can be more serious. And therefore, we are assuming that they are the same, but they may not be the same. And a summary of our findings, and also maybe to help with the discussion later. So we found that poor housing conditions significantly increase the risk of falls. So we identify that electrical and plumbing issues, lack of space, and accommodation being too dark are particularly important. And all of these issues have quite simple and inexpensive solutions. Also, some of the improvement needed to prevent housing-related falls are also likely to improve individual capacity to perform daily activities and reduce care demand. And here I'm saying that fixing the housing problem, fixing a bulb for people to be able to see better, it may have a double benefit. It may prevent falls, but they may also support people with the care need that they already have. Currently, the costs of this fall are substantial, with care making up the largest share of the burden, around 65% of the total cost. So better housing could actually reduce reliance on high cost care. And finally, I think we could advocate, based on these findings, that improving housing quality for older adults should be seen as a key fall prevention strategy that could complement clinical and behavioral interventions. And that's all from me, I think.
Thank you, Javiera. That was a great presentation of your work and your research. And so we can now open up to any questions. So if you want to ask a question, please raise your hand using the reactions. You can raise your hand. We have a question in the chat from Peter Atkins. Peter, did you want to ask your question in person?
Thank you, Stephen. Yeah, my question was with regard to the increase in hoarding that's going on nationally. Sort of what impact that sort of accounted for some of the falls in your area?
Yeah, so hoarding is not one of the specific questions in ELSA, so I cannot look at it. However, it may be already embedded in lack of space, because probably people that have issues with hoarding, they may not have much space. So it is embedded problem in that, but it's not specific to hoarding. And yes, I have heard from local authorities that it's a big issue, but yeah, I cannot account for.
Okay, thank you.
Thanks, Peter.
I think Madeline has her.
Hi, Javier. That's all very interesting. Thank you very much. I was wondering, but in relation to the paper that you and I have been writing about moving, using some of that data, I think, related data, same data set, whether it's possible to look at maybe familiarity. So like we've been looking at some reasons why moving might be good in older age. And would it be possible to look at people who had moved and whether there was any incidents on falls in that way?
Could potentially look at it, I guess. Moving in ELSA with any longitudinal study is not the best, because you tend to lose people when they move But I potentially could look at it, whether the people that move, they have had a previous fall, or I think there is a question where they ask, what's the reason for your move? I'm not sure if falls, or it may be home unsuitability could be one of the reasons mentioned, but I'm not sure about the sample size. I could have a look. Yeah.
Yeah, that would be interesting. And also, I guess, whether people are being visited, because some of the things you mentioned might not be picked up by the person themselves if they've got visual impairments or something, but might be picked up by whether people are visiting.
Yeah, I guess, yeah, maybe I should mention also that as a limitation, in the sense that the home falls are self-reported, but also housing conditions are self-reported, and maybe possible that people don't notice how bad is their home in a way. I know that there is a part of ELSA when somebody external, the person who actually carry out the survey, he write notes about whether the doors they are not accessible or the corridors are too narrow. But I did look into that, and they are very specific whether the person can walk the corridor. So it was not that useful, but there is something there, yeah.
Oh, thanks.
Thanks, Madeline. Roger Oliver.
Yeah, thank you. Yeah, I just wondered. I had to answer the door, but did you mention anything about male or female? You know, any difference between them, and are they the subjects you looked at? Were there percentages of living alone or with a family, or had periods of left unattended?
Yes, so when we identify these factors, for example, lack of space or too dark, we did adjust by gender, for example, and also for whether the person live alone, and other things that I think you mentioned. But for the costing, no, we don't make a difference between who is having a fall. We consider everyone as having the same cost and having the same kind of type of pathway. We don't separate, and mostly it's due to data limitations that we cannot separate them, basically.
Okay. Right, thank you. Thank you.
Thanks, Roger. Florine.
Hi, and thank you, Javier. Unfortunately, I could not be from the beginning at your presentation, but what I was wondering, hearing kind of your conclusions is whether you can identify in ELSA if a person lives in kind of standard housing or kind of extra care housing. So the housing types are housing with care schemes where they probably have also kind of better equipment and adaptations if they need. And if that can be observed, and also kind of assess whether this extra care housing is also kind of helping people to have less falls compared to normal housing.
Yeah, thank you. Yes, we did filter. So the people that I consider in this analysis was only those that were living in their own or rented or social housing. We exclude those that were not living in community living or standard accommodation, as you call it, mainstream accommodation. So yes, they were excluded. So this only is for all the people living in community in mainstream homes. And
Great, thanks, Florine. Any further questions? One question I had, Javiera, was around the extent of home adaptations in the data. To what percentage of, do you know roughly what percentage of those who had falls had home we also reported having home adaptations? Whether that differed.
I don't remember the percentage, but I do have to say that the part of the home adaptations in costing, it was a very small piece of work, let's say. So we made a very big assumption, which was we took from the literature how effective were home adaptations for reducing falls, and that's kind of a big assumption we made to kind of estimate the cost. But yes, I don't remember the percentage of how many people, but for the particular simulation, the decision tree model estimation, we use a big assumption taken from the literature.
Great, thank you. Margaret.
I might have missed it because I too didn't quite get all of the beginning. I had to go away. But did you pick up head injuries as a specific issue? Because I do know that you can not fracture your wrist, but you might you might fall in such a way that you have a head injury, which can be quite serious.
Yes, so it was not picked up as like a unique pathway, but basically we take the cost and the number of people that have had a head injury, and that, well, we can't count from how many of them have had a fall, but we can estimate it. And then we include head injuries and the cost of head injuries based on the proportion of people that had a head injury and was admitted to A&E. So we did consider it, but not like a unique pathway. It was considering the pathway that was injuries. And then it was like kind of an estimation there in terms of the proportion that had one. But yeah, you're right. I think you are mute.
Thanks, Margaret. And then, yeah, Peter in the chat asked Peter Atkins again, a related question to mine was how many are using fall alert devices? Is that available in the data?
I think yes, now I remember. Yes, there is a list of very extensive, at least 15 or 20 maybe, different home adaptations and also aids that people use. I think the majority, I don't know, 50% of them are related to mobility and helping people to go around the home and also to go out. But yes, there are alarms, digital alarms. Yes, I could get the proportion basically. The reason why I didn't use it in the model was because the sample size were getting smaller and smaller because it goes with the branches. So I only use ELSA at the very beginning and then I rely on the literature.
Brilliant. Thank you, Javiera, and thank you all for your questions.